It gives me great pleasure to introduce our speaker today, Dr. Christopher Barnett. Some of you may remember him because he was here for 5 years before moving back to California. So Chris Barnett did his training kind of all over the place. He started in the middle of the country at Northwestern, and then it looks like he came over here to NIH and then went over to California and spent some time there before coming back to NIH, and was head of our CVICU over at Hospital Center for 5 years before deciding that, I guess, or taking on a great position back over there at UCSF. He also ran a pulmonary hypertension clinic over at Washington Hospital Center, as well as here at Georgetown. He's well known in the field of pulmonary hypertension, and I was told early on that one of his specialties was in sarcoid, particularly with pulmonary hypertension. And he's here to give a talk to us today on pulmonary hypertension, a practical guide for the clinician. And so I'm looking forward to your talk, Chris.
Thanks. All right.
Looks good.
Great. So these are my disclosures. So we'll start off with a case, and there's cases through this talk, and I'll try and keep an eye on the time. But if I get close to running out of time, if someone wants to give me a heads up, feel free. So we'll start off with a case here. It's a 42-year-old man with HIV. He uses methamphetamine and presented with the flu. So he was hospitalized with what was thought to be the flu. A couple days later, he was thought to be back to his baseline, and an echocardiogram during the course of his hospitalization was ordered. And his echocardiogram is here on the left side of the screen. This is a normal echocardiogram here on the right side of the screen for comparison. And what you can see here, we immediately see an extremely large right ventricle. We compare that to the healthy right ventricle and on this heart. And you can see a very large right atrium compared to this right atrium. And you can see the septum is pushed over into the left ventricle. So the left ventricle and the left atrium are squished. We look at the, we'll get into this a little bit more, but we estimate the pulmonary artery systolic pressure by using the velocity of the regurgitant tricuspid jet. And in this case, we came to a PASP value of 94. And we also have to add on some data from the right atrial pressure. So in the end, this would have likely even been higher. So on further discussing with the patient, sorry, I have to move the Zoom window because it's covering the slide for me. All right. We talked to the patient a little bit more. Turns out that he had been using meth to treat fatigue related to sleep apnea instead of CPAP. And he also reported that he needed help with household tasks because of worsening dyspnea and fatigue. And the relevant thing here is that for a relatively young person in their 40s, needing help with household tasks is fairly severe exertional dyspnea and symptom and limitation of activity. So there's some questions here. These questions work better when in a live audience, but we'll go through these anyway, and I'll talk about the answers. So which of the following is true? We have a diagnosis of pulmonary hypertension. We should start sildenafil. Next, the patient should be referred to the outpatient clinic for further evaluation. Next, a right heart catheterization is mandatory in the evaluation of this patient and should be performed now. Or next, calcium channel blockers might be useful treatment in this patient. The right answer here is probably C, or is C, and a right heart catheterization is always mandatory in the evaluation of these patients. We'll get into the reasons why these other answers are incorrect later on. But briefly, treatment with sildenafil is a PAH-specific medication, should only be initiated after a full evaluation has been completed. The patient is very sick. We'd probably call this New York Heart Class 3 symptoms. With that right ventricle and those symptoms, that's a marker of very high risk and poor prognosis. So referral to the outpatient clinic would be inappropriate. We'd worry about the patient deteriorating further and potentially dying by the time he was seen and evaluated. And then calcium channel blockers are only useful in a very small subset of patients, and they can actually be dangerous if they aren't correctly used. All right, so pulmonary hypertension, what does this really mean? And it's very confusing because it can mean a lot of different things. So pulmonary hypertension, just the term means that the PA pressure is elevated. So the classical definition of an elevated PA pressure was a mean PA pressure over 25. And note, this is a mean PA pressure. On the echocardiogram, typically what's reported is a pulmonary artery systolic pressure, so not the mean. And in 2019, the World Symposium for Pulmonary Hypertension, this definition was updated to over 20. I think this is slowly being accepted as the correct current definition, although certainly when we talk about prescribing drugs and making clinical decisions, the 25, I think, is still quite relevant. Pulmonary arterial hypertension means something a little bit different. That doesn't mean just that the PA pressures are high, but it's a specific diagnosis. And this is the hemodynamic description of pulmonary arterial hypertension. However, it has to be correlated with the clinical presentation. So having these hemodynamics alone is not enough to make this diagnosis. These hemodynamics are required and necessary though. So PA pressure over classically 25, now we consider over 20. Pulmonary capillary or pulmonary arterial wedge pressure less than or equal to 15 millimeters of mercury, and a pulmonary vascular resistance greater than or equal to 3 Wood units. So this less than 15 is intended to exclude left-sided heart disease, although there's a lot of caveats to that I'll mention briefly later. The PVR is calculated by incorporating the PA pressure, the wedge pressure, and the cardiac output together. PA pressures can be high in a variety of other situations, so we have to ensure that the PVR is also elevated. All right, so this is the current classification of pulmonary hypertension. If you had to remember one slide from the talk, I would suggest this one. And the reason is because this is pretty much the entire differential diagnosis for elevated pulmonary artery pressures. And whenever we approach someone with pulmonary hypertension with high PA pressures, we need to keep in mind this entire differential diagnosis. Group 1 is pulmonary arterial hypertension. As I said, this is a specific diagnosis. This is the name of a disease. This pulmonary hypertension is really a description of a hemodynamic condition, while this is the name of a disease. So PH can be idiopathic, meaning we don't know why patients have it. It can be heritable. Only recently have commercially available genetic tests become available for PAH. So it's now possible to diagnose someone with heritable PH. Typically, in the past, we found this because we find multiple family members of different generations with PAH. Drug and toxin induced. In this case, methamphetamine is the relevant drug. Other drugs can cause this too. Fen-phen, prior to methamphetamine, fen-phen was the one most discussed. Now some agents for treatment of leukemia can cause this also. This list tends to grow over time. Associations with connective tissue disease. Scleroderma is the classic one. Dr. Steen, of course, is an internationally known expert in scleroderma and did much of the work that described the relationship between PH and scleroderma. HIV infection, which this patient also has. Portal hypertension, worth pausing here for a minute. This is not necessarily cirrhosis, but it is elevated portal pressures. Of course, there's an enormous liver transplant population at Georgetown. And these patients, the elevated PA pressures in these patients are particularly important because it precludes liver transplant. And the elevated PA pressures and portal hypertension can be treated to make a patient eligible for a liver transplant. So when you have PAH from portal hypertension, you actually can get about 20 extra points on your MELD score. I'm not a transplant hepatologist, so I don't want to commit to 20 points, but I think it's about that range. And so if you can treat the PAH, then you actually get to transplant quickly. And liver transplant is curative. It's also important to keep in mind that not all portal hypertension is associated with cirrhosis. So even in non-cirrhotic patients, it's important to look for evidence of portal hypertension. Congenital heart disease, and this is typically repaired congenital heart disease. Schistosomiasis, which is probably the most common cause of PAH worldwide. In the last revision of these criteria, PH with that response to calcium channel blockers was taken out as an entirely separate disease process. Pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis, and then persistent PH of the newborn. I'm not going to go through the rest of these in quite as much detail. This PH due to left heart disease, sorry, the HFpEF should of course be its own line here. PH due to lung disease. The key here is that there typically should be hypoxemia. So hypoxemia drives this process. PH due to pulmonary artery obstructions. The most relevant one here is chronic thromboembolic pulmonary hypertension, which we'll talk about a little more. And then PH with unclear multifactorial mechanisms. This includes things like sickle cell disease and sarcoidosis that Barbara mentioned earlier. All right, it's helpful to think about this a little bit. Think about these hemodynamics and which of these groups have which hemodynamics. So we already said, so this figure is pointing out that the location of the lesion in these diseases is in the precapillary pulmonary artery. So this is intended to be the pulmonary capillaries. So this is precapillary disease. So group one, so all the diseases that have precapillary pulmonary hypertension will have the same hemodynamics. So when you get that hemodynamic picture that I showed you earlier, we have to differentiate whether that patient could have group 1 PAH. They could also have PH from lung disease, or they could have CTEPH, because they all show up hemodynamically the same. Group 2 PH from left heart disease, you can the location of the lesion is pretty much anywhere on the venous side. So once you hit the pulmonary venules or onward, so it can be disease in the aorta, disease of the aortic valve, disease of the mitral valve, disease of the pulmonary venous system. There's also we could get more nuanced and talk about mixed types, which are relevant when we get to patients who may undergo transplant, LVAD, and other cardiac procedures. So it is another way to think about these diseases and to understand why the clinical context is so important and why elevated PA pressures, a low wedge, and a high PVR are not adequate to make a diagnosis. I didn't mention this on the prior slide, but PH therapies are really only useful in group 1 PAH. So it's very important to diagnose and can harm other patients with other types of PH. So it's important to make this diagnosis correctly. All right. I just mentioned this, but once again, this is the list of things for which PH therapies are useful. Go into that a little bit more. So most patients who have high PA pressures have left heart disease. So this is a study of patients. I believe this study came from Australia, this population from Australia. But this is reflective of most populations. And this was an outpatient study, although this is probably about the same for inpatients. So most patients who have high PA pressures on the echo are ultimately going to be diagnosed with having pulmonary hypertension from left heart disease. This is a particularly important group of patients because we know that PAH therapies, PAH medications can cause harm in these patients with left heart disease. They're not beneficial and can cause harm. So we really want to we need to ensure that we make the correct diagnosis so we don't give PAH medications to these patients. You'll see a small group of these patients are going to have group 1 PAH. A small group are going to have CTEPH. The second largest, lung disease. And again, an important group because most PAH medications are contraindicated in these patients because they can cause harm. When we look at pulmonary hypertension worldwide, most of these patients are going to, as I mentioned, will have schistosomiasis. A group will have high altitude related pulmonary hypertension, which falls in group 3. This is essentially hypoxemia induced pulmonary hypertension. HIV is also thought to be a significant amount of pulmonary hypertension worldwide. If you look at all of the patients living with HIV now, and we don't understand well how HIV causes PAH. Or which patients with HIV get PAH. But when we look at estimates from Europe about the frequency of PAH in HIV patients, these are patients treated on therapy, it's quite high. So this group has a lot of potential to be a very large amount of PH worldwide. This looks at a European cohort, and this is a little bit older data. But this is about the same now as it was then. There's been some demographic shifts as we've identified. We identify more patients with PH. They tend to be, we diagnose it older, in older patients now, and more often men. However, this spread I think is still about correct. So in this cohort, most of the patients were idiopathic, some familial, a large group with connective tissue disease, congenital heart disease, portal hypertension, anorexigens. I suspect if we had a newer survey, there would be a lot of methamphetamine in here, HIV, and then multiple factors are also quite common. Survival in untreated PH is poor. So this is data from an NIH study from many years ago. This data was collected starting, I believe, in the 70s through the 80s. And you can see here that patients, and most of these were relatively young women. Those were the patients we were making the diagnosis of PH in at that time. You can see that these patients, and again, these are relatively young people. You can see that after about 2.5 years, half of these patients have died. So it's quite a severe disease, and this is without treatment. There's also variation by etiology and survival. Patients with congenital heart disease tend to do the best, and we think that's probably because their right hearts were exposed to these high flows and high pressures from the moment they were born. Therefore, their hearts remodel and tolerate the hemodynamic abnormalities much better. Portal pulmonary somewhere here with idiopathic. HIV at one point was a very grim diagnosis. You can see here in this series in the early 2000s, about 20% or 80% of patients with HIV-associated PH were dead in 3 years. So a very grim prognosis, and we have to treat them very aggressively. Connective tissue disease, you can see here, also has a very poor prognosis. So with therapies, and this data is a little bit older, but this data is in the era of modern therapies. We've really had very little new become available since 2010. So this predicted line here comes from the NIH registry I mentioned earlier. And this was the observed mortality in this population. So you can see even with therapies, at 1 year, we still have 10% mortality at 24 months, 70-ish% mortality in these patients, despite the availability of modern therapies. So the mortality remains very poor, even with the therapies that we have. This is another cohort study showing essentially the same thing. And so this is the REVEAL cohort. This was published in 2012. And you can see about the same thing here. At 3 years, about 30% mortality, 67% survival. So quite a grim prognosis. This is a calculator. So we mentioned a little bit earlier about a prognosis, in particular when we referenced the case that we talked about. So it's useful to the REVEAL, these cohort studies that have that looked at patient mortality. That data has been used to create calculators and prognostication tools. We use those tools quite a bit, and I think it's useful to look at our individual patients and try to understand their prognosis. This partially helps us understand how aggressive we should be with therapy and what therapies we should be instituting. And this calculator is available online. This is the REVEAL calculator. I would encourage you, if you have a patient with Group 1 PH that you take care of, to plug their data into this calculator. And this gives you a really good sense of how sick they are. We don't have all the data I didn't present all the data necessary to risk assess this patient that we mentioned, that I showed you at the beginning. However, you can see here that the patient's going to have advanced New York Heart Association class. If we tried to walk this patient, they'd have a low 6-minute walk test, likely a high BNP. So they have numerous features that suggest high risk. This is the data, so the highest risk cohort in REVEAL. So before I showed you cumulative survival in all comers, this breaks it down by the REVEAL score. So if we calculate a high REVEAL score, you can see in the highest risk patients, at 1 year, less than half of them are still alive. The lowest risk patients, they have quite good survival and outcomes. And again, if we were to go back and if I gave you all the data, and we were to calculate the REVEAL score for our patient, it would probably be, he would probably fall in this red or orange line or somewhere in between, suggesting we need to be very aggressive with therapy. So pathophysiology, this is the only slide I'll show you, and this is, it's fairly complex, and it becomes more kind of complex all the time. I think early on, there was a review recently, and the reviewers commented that early on we had we thought maybe there would be a few mechanisms that cause the development of PH in patients. And as time has gone on, we found more and more and more complex pathways and mechanisms. And this is still relatively poorly understood. This is a bit of an oversimplification, but I think it's a useful way to think about it. Essentially, in patients with PAH, we have an excess of vasoconstriction and proliferation moderators, in addition to thrombus formation. And we have a deficiency of factors that cause vasodilatation and apoptosis. So when we look at the pulmonary vasculature, you can see here a normal looking pulmonary, precapillary pulmonary arterial. First, we get smooth muscle, then we get smooth muscle and neointimal formation, then we get plexiform lesions, and then we get this thing that looks like bacon and eggs, which all of these seem to look like bacon and eggs at the end. But you can, so we have proliferation, and then thrombosis becomes a part of this also. The development of plexiform lesions is considered pathognomonic for group 1 PAH. However, we do find these pathologic changes, so muscularization, smooth muscle hyperplasia, and neointimal formation in other forms of pulmonary hypertension, including group 2 from heart disease and group 3 from lung disease. But the plexiform lesion is still thought to be a feature of group 1 PAH. These are some examples of a normal pulmonary arterial and a plexiform lesion histopathologic appearance. This is an example. I like to show this because I think it's very interesting. So the MEC Schistosomiasis is classified as group 1 PH because the schistosoma eggs have been associated with plexiform lesion development. And so this is why schistosomiasis is grouped in group 1 PH. So this is really one of the other main slides, I think, to remember from this talk is patients with PAH and really any kind of pulmonary hypertension, left heart disease, from lung disease, from CTEPH, they die because they have worsening RV failure. So the pulmonary hypertension itself doesn't cause death. It's worsening of the right ventricle. So as PA pressures start to rise, as I mentioned, the PVR will also rise, and the PVR is calculated. It's a combination of the PA pressure, the left-sided filling pressures, and the cardiac output. As the PA pressure gets high enough, the right ventricle will start to fail. As the right ventricle fails, the heart no longer pumps blood, and the cardiac output will start to drop. At some point, because it's necessary to have flow to generate pressure, the PA pressures will then start to drop. So one of the reasons that if you look at risk calculators and scoring systems for prognosis in pulmonary arterial hypertension, the PA pressure itself is not a risk factor. So the higher the PA pressure does not mean the disease is worse. The lower the cardiac output, the higher the PVR, the worse the right ventricular function. Those things suggest worsening disease. In fact, as patients get sicker, the PA pressures start to go down. And that's because the right ventricle can't generate pressure anymore. I was fooled by this once a long time ago. A patient I was taking care of in the clinic presented with worsening symptoms and signs of RV failure. He went to the cath lab, and the cath lab team called me to tell me that I had the diagnosis wrong because his PA pressures were actually quite low. And what we found out quickly was his cardiac output had dropped precipitously. And the reason his PA pressures were low was not because we had misdiagnosed him, but because he actually was in decompensated end-stage RV failure. So it's really important not to focus on the PA pressures. In clinic, in fact, when we see these patients in pulmonary hypertension clinic, funnily enough, the thing that we're typically least interested in is their PA pressure. What we're most interested in is their functional status, their ability to walk, the size and shape of the right ventricle, their cardiac output. Once we make the diagnosis, the PA pressures are not typically very important to us. They don't guide our therapy. All right, so we'll go back to our case. So which of the following studies should be done to further evaluate the cause of the pulmonary hypertension? This is in our HIV infected patient who uses methamphetamine. The answers are plasma, BNP, and ANA, a sleep study, a CT pulmonary angiogram, a liver ultrasound. No further studies, pH is from HIV. Here, the answer is really all of these above. It's at least A, B, and D. In some cases, it's C. Definitely not E. As I mentioned, all patients require a comprehensive evaluation to identify all contributors to the elevated PA pressures. Certainly possible this patient could also have cirrhosis. We identified this patient. We know from our history that the patient has sleep apnea that is untreated. The BNP and the ANA is diagnostic, the BNP is prognostic. A CT pulmonary angiogram may be useful to look at lung parenchyma, can be useful to look for congenital or to get a pulmonary artery anatomy. It is not useful to diagnose chronic thromboembolic pulmonary hypertension. CT pulmonary angiography is great for acute pulmonary embolism, but not for chronic thromboembolic disease. We'll talk about that a little more soon. All right, so assessment of pulmonary hypertension. I think this is this cartoon is great and very instructive, because this is, if only we could do this. And this sort of gives you an idea of how complex assessing these patients is, because it's extremely hard. It's about as hard to assess these patients as it would be to put a blood pressure cuff on their lung. So in many of these patients, the first test we get is the echocardiogram. And I think it's important, again, to look at what other information comes from the echocardiogram other than the PA systolic pressure, because the PA systolic pressure is frequently, as I mentioned, not the most useful, after we make the initial diagnosis, not the most useful feature on the echo. So we always want to look at the left ventricular systolic function. As I mentioned, the most elevated PA pressures are going to come from the left heart. So we have to look very closely at the left heart. Want to look at valvular function. Valvular disease, especially mitral regurgitant stenosis, are often a cause of pulmonary hypertension. We want to evaluate the right ventricular systolic function and estimate the PA pressure. So this is how we estimate the PA pressure on echo. So this is the right heart, this is the right ventricle, right atrium, and this is the velocity of the blood flowing backwards across the tricuspid valve during systole. So we use this is, we put a cursor on this envelope and measure the highest velocity blood flow across that regurgitant blood flow across that tricuspid valve. And that gives us a pressure gradient between the right ventricle and the right atrium. In this case, a gradient of 55. To this, then we add on the right atrial pressure. There are a variety of ways to do that. In many labs, right atrial pressure is estimated from collapsibility of the inferior vena cava, although some echo labs will add on a standard number. There are pitfalls to this assessment. Typically, it's, as you can see here, so this is an apical four-chamber view up here. This is a subcostal view. Typically, we look at the tricuspid jet from multiple different echo views, so at least 3-4 views. And the reason is because that jet may only be visible in some of those views, not all of them. Here's a good example of a jet, and where there's no visible jet to estimate a PA systolic pressure. And we have to be cautious when a PA systolic pressure is reported in an echo report that we have had a good quality jet to measure. So here I would argue that I wouldn't know where to put that cursor because none of these envelopes is complete. Here we have complete envelopes, and it's quite easy here to decide where the highest velocity is, where to put that cursor. However, the question we always have to ask is, this is the highest velocity that we measured on the echo, but is this the highest velocity inside the patient's heart? Does this truly and accurately reflect the patient's pulmonary artery pressures? And we know that it frequently doesn't. And this is part of the reason why right heart catheterization is so important. So this is some data from back in 2011 from Northwestern. And they looked at the correlation of the PA systolic pressure on right heart catheterization and echocardiography. And you can see that it's pretty much a scatter plot. There's data everywhere. So oftentimes the difference between the PA pressure measured on echo and the PA pressure on the right heart cath can be quite remarkable. In fact, there was a patient I took care of at a hospital center a number of years ago. She had an unmeasurable PA pressure because about 20% of patients don't have a TR jet. So it's not possible to use echo to estimate their PA pressure. She was one of those folks. However, she had another family member with group 1 PAH. She had presented with syncope. And when we finally got her to the catheterization laboratory, her PA systolic pressure was 90. And she had multiple echoes before that, none of which were able to measure or estimate a PA pressure. So really important, even if the echo doesn't suggest pulmonary hypertension or high PA pressures, if the patient's clinical presentation otherwise does, then further investigation is still required. And we can certainly end up diagnosing a group 1 PAH or another type of pulmonary hypertension, even if the echo does not suggest elevated PA pressures. These are some examples of echocardiograms. There we go. So these are normal echocardiograms. These are just two views here on the left side of the screen. And this is an apical 4-chamber view. This is the right side of the heart, right ventricle, right atrium, left ventricle, left atrium. This is a short axis view. So this is the left ventricle, and this is the right ventricle here. We can see in this patient with group 1 PAH that the right ventricle is large, that it's thickened, the right atrium is thickened, that the right ventricle doesn't get much smaller during systole. You can see here that the left ventricle is quite compressed, the left atrium is quite compressed, suggesting that the pressures in the right ventricle and the pressures in the right atrium are quite high, higher. Here, the right atrial pressure is higher than the left atrial pressure. In the short axis, we see some other findings. We see flattening of the septum. You could be concerned that the right ventricle is large, although hard to say from this view for certain. But this septal flattening and the motion of that septum suggests abnormalities of the right ventricle. And these are quite severe abnormalities. Assessing the right ventricular systolic function is very difficult with echocardiography. And the echoes I just showed you are very high quality images that I would argue we can see the right ventricle very well. Oftentimes the right ventricle is very hard to see, especially when the right ventricle is healthy. Sometimes it's hard to see it at all. These are some of the methods that we use to assess the right ventricular systolic function. Some of these you may find in an echo report, some not. And it depends largely on the echocardiographer's presence. So we can't do an ejection fraction of the right ventricle with standard 2D echo because it has a crescentic shape that is not favorable to the assumptions that must be made in order to calculate an ejection fraction. So what we do instead is we can measure the area of the RV during diastole and the area during systole. We can measure the motion of this tricuspid annulus, where the tricuspid valve connects to the right ventricle towards the apex. This is what's called a TAPSE, tricuspid annular plane systolic excursion. And this is an example of how that's measured. So this picture is obtained, then we use that to create an M-mode image. And then we measure the distance. This is that annulus. We measure the distance that it goes. So here, 2.4 centimeters. We can also measure how fast the annulus travels. And these three things together are pretty much the best things we have on echo. Oftentimes, we can't see the annulus. We can't find the annulus to measure velocity, or we can't see the free wall well, and we can't measure these areas. So it can be extremely challenging to assess RV function on echo. MRI is really the gold standard for RV function at this point. And with MRI, because we can obtain volumetric measurements, we can calculate an RV ejection fraction. 3D echocardiography is not routinely performed, but can be used to measure an RV ejection fraction also. However, it's not frequently available. All right. So now if we have somebody who has an echo, and I don't go much into other things like exam, ECGs, chest x-rays, because oftentimes they are not particularly helpful. They're quite insensitive. Most of these patients will end up with an echo. So if you have an echo with an elevated PSP, and the question is, how worried are you for a diagnosis of PAH? And I would say also we can incorporate other things into this, decide how worried we are based on incorporating other data, such as the size and shape of the right ventricle, the function of the left ventricle. So we decide how worried we are about group 1 PAH or any other type of pulmonary hypertension. We look for other diseases to explain the elevated PASP. For example, if we find a patient has mitral stenosis, then we would want to treat the mitral stenosis. So we treat the other medical problems that are present, and then close follow-up for symptoms and repeat. So a good example would be a patient with obesity and sleep apnea. PA pressures are high. We counsel them to lose weight and have a sleep study and use CPAP. They do these things. We can follow up to ensure that their symptoms are improving and that their PA systolic pressure and RV are not worsening. Intermediate clinical suspicion for PH, and we have indeterminate echo findings. We may want to move directly to a right heart catheterization. High clinical suspicion, especially if there's the presence of a disease associated with PH, we really need to get those folks to a PAH specialist quickly, get a complete evaluation done, including a right heart catheterization. Really, and these aren't fixed rules. I think this varies quite a bit depending on available testing, what patients are worried about, how severe their symptoms are, the presence of other diseases. But this is, I think, is a general reasonable workflow. As I mentioned before, right heart catheterization is mandatory for this diagnosis. It's the gold standard for the measurement of the PA pressure and to obtain other hemodynamic measures such as the cardiac output and index of the pulmonary artery wedge pressure. It helps us confirm our diagnosis. One key to this is the ability to obtain a high quality wedge pressure. And this is not always easy, especially in patients with diseases like chronic thromboembolic pulmonary hypertension. The other situation may be when the right ventricle is very large and the left side of the heart is very compressed. The pressures may appear to be elevated in the left heart. That may be an artifact of the severity of right ventricular abnormalities. In patients in whom we can't, a reliable wedge can't be obtained, then we consider putting a catheter directly into the left ventricle. And in the cath lab, this is a fairly straightforward thing to do most of the time. Also, and we don't routinely do this, but there are some institutions that have very robust exercise protocols to try to precipitate elevated PA pressures with exercise. In particular, the Brigham and Women's Hospital has a protocol where patients have a PA catheter placed, an arterial line placed. They exercise on a bicycle, and they obtain wedge pressures and PA pressures and other hemodynamics about every minute through exercise, and can provide very, very high fidelity data to help understand the exercise pulmonary hypertension. Saline infusion is sometimes used to try and elicit left-sided heart failure that may not otherwise be seen. As you can imagine, patients, if they're taking their diuretics, they've been NPO, they're lying still on a table, we don't always see the elevated wedge pressure. Vasodilator challenge, we'll talk about a bit more in a minute, but this is only done in a very select group of patients to determine if calcium channel blockers are a useful treatment for them. And then also the right heart catheterization is useful to determine the disease prognosis. As I showed you in the prior slide, when cardiac output starts to fall, that means you have progressive and severe right ventricular failure. Here's an example of a PA catheter going through the heart. So it goes into the right atrium and the right ventricle, out with the pulmonary arteries into the wedge position. So this is a right atrial tracing. This is a right ventricular tracing. This is a PA tracing, and then this goes to a wedge tracing. The other elements of the evaluation really also have to be done. There's really no exceptions to this. All patients have to have a complete evaluation. So the echocardiogram, useful, of course, for left heart disease, a VQ scan for chronic thromboembolic disease. I'll mention here again that this is really mandatory. Pulmonary angiography, CT pulmonary angiography, it's not a replacement for the VQ scan. It is frequently not a useful test to detect chronic thromboembolic pulmonary hypertension. A non-contrast CT scan of the chest, frequently a high-res CT, is needed to exclude interstitial lung disease and other lung disease that can be contributing. A sleep study, I typically start with nocturnal pulse oximetry, which is easy to obtain. Sleep studies are much harder, of course, to obtain. Serologies for HIV, connective tissue disease, if appropriate, schistosomiasis, liver ultrasound for portal hypertension, and I'm always careful to ensure that we get Doppler flows on these liver ultrasounds. Again, even patients without cirrhosis can develop portal hypertension and the right heart catheterization. Some of the other things we think about, of course, this is sort of the basic minimal requirements. If we do a CT scan, Barbara mentioned sarcoid earlier. If we do a CT scan and there's adenopathy, that suggests a diagnosis of sarcoid, and we should pursue that diagnosis. If a patient is anemic, that may suggest a diagnosis of some sort of hemolytic syndrome, which requires further diagnosis. So we really have to understand all these medical problems very well because they all can raise the PA pressures. All right, so we'll jump here to a different case. So this is a 58-year-old with known ischemic cardiomyopathy, has an echocardiogram for worsening symptoms, and we find this. So this is the right side of the heart, and we can see the right side of the heart is quite small. Here's the left side of the heart. You can see this very large left ventricle. There's minimal thickening of the myocardium, and the ejection fraction would require additional views to calculate. However, I think we can ballpark a very low ejection fraction. We'll give it 20%. And you can also see here a very large left atrium. Now, this patient also has quite a high PA pressure. We have I can't even tell, oh, this is an RARB view. This PA systolic pressure was obtained. Again, we'd have to add on the right atrial pressure, which we don't have in this slide. So the PA systolic pressure is 48 plus right atrial pressure, so this could be easily as high as 68 for PA systolic. So the question is, what do we do next? So we have a very high PA pressure. Is the answer to start treatment with a phosphodiesterase inhibitor, start endothelin receptor antagonist like Macetent or ambrisentan, refer for advanced heart failure therapy evaluation, optimize standard heart failure medications, optimize volume status. I would argue that C, D, and E are the correct answers. A and B are incorrect. So this is somebody we definitely don't want to start PAH medications in. Phosphodiesterase inhibitors are not useful in left-sided heart disease, and endothelin receptor antagonists worsen outcomes in left-sided heart disease. So it's critically important to understand the entire picture and not anchor or react to the elevated PA systolic pressure in isolation. These are some of the targets of PH therapy. So really at this point, we have three pathways, and this may be changing soon. There's a couple new drugs that have shown some benefit in trials that are being completed or have recently completed. So there will likely be at least a fourth, if not a fifth class of medications added to this slide sometime soon, and lots of other drugs in the pipeline. So the endothelin pathway and these are all fairly straightforward. In patients with PAH, it was found early that they have too much endothelin. This is a very potent vasoconstrictor, so we block endothelin. They didn't have enough prostacyclin, so we give back prostacyclin. And now we have a drug also that can directly activate the prostacyclin receptor. The nitric oxide pathway, these patients are deficient in nitric oxide, so we can use phosphodiesterase inhibitors or soluble guanylate cyclase stimulators to increase the activity of nitric oxide. The prostacyclins can be delivered several ways. The classic prostacyclin is epoprostenol. It was branded as Flolan. We have the additional prostacyclin, treprostinil now. Epoprostenol has to be given by continuous IV infusion. Treprostinil can be given by IV or subcutaneous infusion. Either way, patients have pumps they have to fill and manage. Iloprost is still available, very rarely used. Tyvaso treprostinil is the inhaled formulation of treprostinil. You can see here, though, this inhaler is quite cumbersome. This picture is a little bit old, but the current inhaler looks very similar to this. There's also oral a version of treprostinil available now, as I mentioned, also selexipag, which is a prostacyclin receptor agonist. So epoprostenol has a fairly remarkable, and this is old data, so these were sick patients who had no other therapies, but you can see here in a 12-week study, 20% of the conventional therapy group died, and no patients in the epoprostenol group died. So and this trial was not designed to assess mortality, but you can see the mortality signal is very, very strong. In 12 weeks, 20% of your control group has died, and none of your treatment patients have died. It's a fairly remarkable effect. So this remains the gold standard for sick patients, epoprostenol. Endothelin receptor antagonists, we have bosentan, ambrisentan, macitentan. The main differences are their selectivity for the receptor. The big things to keep in mind here are that these are highly, highly teratogenic medications, and they require special handling, special approvals. The prescriber and the patients have to both sign up for a risk mitigation program run by the FDA, or run by the companies mandated by the FDA. Bosentan is rarely used anymore, but requires monthly LFT monitoring. These drugs also can cause edema to accumulate, and especially in use of left heart disease. They were originally studied in left heart disease, and they worsen, they increase the risk of hospitalization and increase fluid retention. They can do that even in appropriately selected PAH patients, so have to be used with quite a bit of caution. And you can see here, this is the data from the early bosentan trial. The patients treated with bosentan walked further at the end of a 16-week study. This is the trial from this is the data from the trial that got macitentan improved, and in this case, there was a composite endpoint. So this was a much larger trial done much more recently. Now there was a composite endpoint including mortality. This was the first mortality endpoint in the PAH trial. So macitentan, we can say that it improved survival. Nitric oxide pathway, we mentioned we have two phosphodiesterase type 5 inhibitors, sildenafil and tadalafil. Difference is really in their half-life. Sildenafil has interactions with HIV therapy, tadalafil less. These have very important interactions with nitrates. If nitrates are given with these medications, they can precipitate life-threatening hypotension. We also have the soluble guanylate cyclase agonist, riociguat. This drug is a little harder to use because it does lower blood pressure, has to be titrated slowly over months. It's also highly teratogenic and has REMS programs, a REMS program is required. And again, sildenafil, this is the data we have, improved exercise tolerance after 12 weeks on therapy. I'm gonna go by this slide fairly quickly. This just is a comparison of data from the REVEAL trial, data comparing some patients in the REVEAL study with patients in the NIH cohort, showing this improvement in survival. Again, though, I think it's as big of an improvement this is, what's more remarkable is how poor the prognosis still is. So clinical targets of therapy, these are the things we think about. As I mentioned, the pulmonary artery pressure is not on the list, but we want to improve the functional class. We want a 6-minute walk distance that increases. And again, this is part of the reason we do. When I was at hospital center, we did 6-minute walk testing on every patient, every visit, because this is one of the most important markers of prognosis, and we can do this easily in the office. If somebody does CPETs, they can measure peak oxygen consumption. We want the BNP to normalize. We want the echo to have normal RV structure and function, a low right atrial pressure, and a normal cardiac index. So this is what we're trying to achieve. And again, I emphasize again, because it's so important, that the PA pressures are not present here. They're not part of our treatment targets. I mention this again also because it's very important. If we use these drugs, and these are two endothelin receptor antagonists that did not get FDA approval, but we have lots of data that these drugs are not useful or harmful in left heart failure. So really important to ensure that these patients don't have left heart disease. Treatment with these drugs in those patients can be quite dangerous. In COPD, this is another setting. So in lung disease, PH therapies are not always useful, and that may be changing. There's Tyvaso was recently approved in interstitial lung disease, And the trial in COPD, I believe, is still ongoing, but I anticipate it will be approved for both indications. The oral medications are not useful generally. There's a lot of nuance to that statement, but in general, a patient with COPD with high PA pressures, in prescription of these medications worsens gas exchange and doesn't improve outcomes. I'll comment that in patients with significant lung disease who have significantly elevated PA pressures or RV dysfunction, typically lung transplant, if they're a transplant candidate, is the optimal treatment. Most of the PH medications are not going to be particularly helpful. Sometimes PH medications are started in patients to try to improve their RV function while they wait for lung transplant. But these are not a treatment for PH from lung disease. In IPF, macitentan actually worsened outcomes. Now, this trial was not designed to test the patients with pulmonary hypertension from IPF. It was looking at anti-inflammatory properties of macitentan. However, patients with ILD did worse with macitentan. So ERAs are generally not used in ILD, and if used, should be used with great caution and careful monitoring. Calcium channel blockers. This is an important slide. Calcium channel blockers are the agent we had prior to the advent of epoprostenol. Calcium channel blockers are useful in a very small percentage of patients. And so this was a study done in the mid-2000s. And these authors went back and they looked at the patients who benefited from calcium channel blockers. And you can see these are the folks who are termed now responders. And those patients survived for a very long time. Patients who were termed non-responders, they died very quickly. These response criteria changed around this time in 2005. Unfortunately, there are a variety of other criteria that existed before this, which are still often quoted. But in order to for a patient to be classified as a likely long-term responder, during a vasodilator test in the cath lab with the right heart catheterization, and I won't go into the nuances of the vasodilator test, but the mean PA pressure has to drop by at least 10 and go under 40. Even if this happens, these patients require repeat vasodilator testing over time because sometimes this vasodilator response is lost, and then they join this group with much higher mortality. So this has to be done very carefully. This is quite uncommon. Really, it's only in idiopathic PH patients. Most of the other group 1 causes of PH are not, those patients are not suitable for calcium channel blockers, and vasodilator testing does not need to be done. Other therapies. So this is actually, I apologize, this slide, I should have taken off Coumadin. So Coumadin was used in the past, is no longer recommended. In fact, is associated with increased bleeding, so should not be used. DIG, oxygen, diuretics, oxygen, DIG, much like left heart failure, these are useful. We do want the oxygen saturation in these patients over 90% because hypoxemia causes more pulmonary vasoconstriction. Pulmonary rehab, there at hospital center, we send all of our patients to pulmonary rehab. And there's a growing body of literature suggesting that patients with pulmonary hypertension benefit tremendously from pulmonary rehab. So this is an incredible useful thing to do. So a third case, and so we'll I think that we're almost done. We have about 5 minutes, I think. We'll go quickly through these. So 69-year-old male with a history of PE, 3 years of dyspnea, chest discomfort, syncope, and edema. So presents with this very severely abnormal right ventricle, a elevated PA systolic pressure on echo. Next step, CT angio of the chest, BQ scan, right heart cath, referral. You could actually probably do B, C, or D. Here, the only wrong answer is A. And again, CT angiography is not a test that can be reliably used to exclude CTEPH. A BQ scan is. Defining the patient's hemodynamics and getting them to a CTEPH specialty center would also be reasonable things to do. Just briefly, CT angiography, again, highly variable sensitivity, depending on the study, 50 to 100% or near 100% sensitive. However, these high sensitivity values come from small studies done, research scanners, research attendings, research patients, and routine clinical CT angiography, I think, is not this reliable. VQ scanning is still the accepted standard. This patient had poor hemodynamics. So this is an example of a conventional pulmonary angiogram. And you can see here these numerous abnormalities, and these are termed webs. You can see the vessel gets tight. There's a little waist there. You can see them here and here. And you can imagine why this is not visible on CT angiography. How this would be very hard to see. Now that the patient's diagnosed with CTEPH, treatment should include surgery, anticoagulation, sildenafil, riociguat, no further treatment. The answer here is surgery and lifelong anticoagulation. It's important to understand that CTEPH is a surgical disease. Riociguat is approved for therapy. However, it is only approved in patients who either decline surgery or are inoperable. And there are other techniques now, catheter-based techniques that can be used to treat CTEPH also. CTEPH surgery is pretty remarkable. This patient went in with a high PVR, came out with a low PVR, normal cardiac index, and much lower PA pressure. CTEPH is a little bit of a poorly understood disease. We have these data. I think the most important data point is that most patients who have many patients who are diagnosed with CTEPH have no history of PE or DVT. So it's very important that the absence of a history of a clot does not exclude CTEPH, and a VQ scan is mandatory in all patients with elevated PA pressures and RV dysfunction, especially if they're thought to be significant and treatment is desired. Without intervention, and intervention being surgery, mortality is high. Another example of a pulmonary angiogram, this one is fairly dramatic, missing a large portion of the pulmonary artery. You can see here in patients who have elevated PA pressures who don't have surgery, mortality is extremely high. They tend to die. Patients who do have surgery, the mortality survival is very good. And this is probably better now. This data comes from San Diego, and they're up to many, many more patients since this was last published. This is what comes out during CTEPH. So the surgery requires opening the pulmonary artery and extracting this material. And you can see these are casts of the pulmonary arteries. I have a whole, if I see anybody in person, you can ask me to show you my very large collection of endarterectomy specimens from all the patients we sent for endarterectomy when I was in the hospital center.